Hello, and thank you for your attention. My name is Kelsey Eaton, and I will be presenting our project, Tracheostomy Decannulation, a retrospective review of predictive independent variables for decannulation subtype. There are over 100,000 tracheostomies performed in the US on an annual basis, often for vent-dependent respiratory failure patients in an ICU setting or addressing impending upper airway obstruction due to inflammation, infection, head and neck trauma, or cancer, and associated treatments. Inherently, there's a foreign body reaction with the tracheostomy tube, which can range from simple stomal granulation tissue to complex issues such as tracheal wall erosion, subsequent bleeding, as well as mucus plugging distally, as outlined by the general spaces within Figure 1. Currently, there are no clear acceptable guidelines for tracheostomy decannulation, which prompted our study. The specific aim of our study was to evaluate independent factors that may play a role in successful tracheostomy decannulation in comparison to binary dependent variables, that being of single-stage decannulation versus a more traditional tracheostomy decannulation, of which we will detail further. Our data was collected from the Clinical Surgical Database of Detroit Medical Center from 2013 to 2020. Inclusion criteria involved those with a tracheostomy and were over 18, and those that were excluded were those that had incomplete information regarding their tracheostomy decannulation, as well as comorbidities. Each decannulation candidate must have met minimal clinical criteria, which involved passing a swallow study with no aspiration, secretions were minimal to none, vent independent for over 72 hours, and level of consciousness of ANO times 3. They then underwent flexible fiber optic laryngoscopy evaluation with scoping through to evaluate vocal cord motion as well as aspiration, then through the tracheostomy stoma evaluating the distal trachea as well as the subglottis. Examples of concerning findings that may have prohibited decannulation are found in Figures 6 and 7, indicating subglottic stenosis as well as obstructive granulation type tissue. Patients then underwent a single stage or a traditional staging of tracheostomy decannulation, with single stage undergoing full decannulation at the time of endoscopic evaluation with occlusive dressing and being admitted to the hospital overnight and then discharged the following day, or traditional with downsized to a size 4, being capped and again admitted overnight and evaluated for any signs of airway distress and then discharged the following day. Our power analysis demonstrated that for a 99% confidence interval, we needed 21 individuals within this study, with our subjects totaling 93 after meeting full criteria. Multiple statistical analyses were performed, including a multi-nominal logistic regression, which was used to determine predictive relationships between the independent variables studied, which included BMI, hypertension, diabetes, COPD, stroke, motor vehicle accidents, heart disease, psychiatric history, seizures, age, and sex. In comparison with that of dependent variables, which were the successful tracheostomy decannulation through either the traditional method or the single stage method outlined above. Of the 93 patients that met inclusion and exclusion criteria, 57% were male, 43% were female. There was a broad array of BMI distribution as evidenced in the histogram above, as well as age. Our multi-nominal logistic regression indicated that there were none of the independent variables were predictor of success for traditional versus single stage tracheostomy decannulation, except for that of motor vehicle accidents, which demonstrated that these patients had successful tracheostomy decannulations were performed by the traditional method rather than single stage. Decannulation must be approached judiciously. And so taking this information and applying it into the clinical world is important. Up until now, there were no clear guidelines that designated the correct protocol or criteria, inclusion criteria for those undergoing decannulation. This led to the decisions to proceed being made by either the expertise of the individual surgeon or a multidisciplinary team. Evaluation is complex, as are the functions for being successfully decannulated, as it involves the brain, swallow, coughing, inflammation, as well as respiratory muscles. Traditional methods were time-consuming, but with increased length of stay in the hospital, as well as increased possibility of nosocomial infection, increased cost due to the longer hospital stay, as well as the possibility that there was increased respiratory resistance, which may have led to failures that would not have otherwise occurred. Given these aforementioned disadvantages, a single stage after 3-step endoscopic evaluation is very attractive as it avoids these disadvantages. Our study demonstrates that there's no significant difference between successful tracheal decannulation techniques, the traditional versus the single stage, in regards to any of the independent variables listed prior. The lone caveat for this is those who suffered a motor vehicle accident prior, indicating that the traditional tracheostomy decannulation was successful in these settings more than single stage. We hypothesize that this may be due to the overall neurologic status of the patients, despite being A and O times 3. Acknowledging the sample size limitation of our study, we cannot provide a definitive recommendation for how to proceed with decannulation. However, we believe that this highlights that there's no significant difference between traditional and single stage. We thank you for both your time and consideration in listening to this presentation.